Welcome, everybody, to today's IAS-USA webinar. We will be starting in a few minutes, but I want to encourage everyone to answer the questions on the poll that you see in front of you so that we can understand our audience and what their interests are. All right, thank you so much for joining. This is going to be a fantastic hour and a quarter. I'm Wendy Armstrong. I am at the University of Colorado, Anschutz Medical Campus in the Division of Infectious Disease. I'm excited to hear Dr. Peter Chin Hong, who I'll introduce in a minute, talk to us about emerging infections and global outbreaks, implications for HIV and infectious disease care in the United States. But first, I want to go through some introductory slides. Here you can see the conflict of interest or the disclosures for our content on the web board for IAS-USA. Next, you can see the disclosures for myself, Dr. Chin Hong, and the reviewers, the peer reviewers and planners of this webinar today. Our webinar today has been designated by IAS-USA as a live activity for a maximum of 1.25 AMA credits. It is also eligible for ABIM MOC points, nursing, pharmacotherapy, and pharmacy contact hours. And so please feel free to be sure to claim those in whatever category applies to you. We have had generous support for this activity received from the following contributors that you can see there, the platinum supporters and the additional supporter, Gilead, Merck, ViiV, and Hologic. So today there will be separate windows showing poll questions, and we will have a couple of poll questions to start out the session. The responses will be displayed after the poll closes, and the answers will be disclosed later in the presentation. Please feel free to submit questions. You can do those using the Q&A button, and when you do that, please include your full name and your institution. If you work for a government agency and don't wish to be more specific, please just write government agency in the space for institution. The chat function is actually allows discussion between you, the attendees, but it will not be moderated or seen by myself or the presenter. So again, if you have questions, please put them in through the Q&A button. And so now I'm excited to get started. I want to introduce Dr. Peter Chin Hong. Dr. Chin Hong is a professor of medicine and the associate dean for regional campuses in the Division of Infectious Disease at the University of California, San Francisco. He completed undergraduate and medical school at Brown University. He trained in internal medicine and completed his ID fellowship at UCSF. He was the founding director of the Immunocompromised Host Infectious Disease Service at UCSF and the recipient of the 2022 Sagan Prize for Science Popularization for his work with COVID-19 and other emerging infections. Dr. Chin Hong has been a really important spokesperson for infectious disease and for science through multiple outbreaks, and in addition has won numerous teaching awards, and he brings them all together, I think, today in this webinar. So, Dr. Chin Hong, I'm excited to hear your presentation today.
Let me share slides. Thanks so much, Wendy. It's an honor, a true honor to be on with you. Wendy, you've done so much for our field, particularly for our trainees and medical education. So I thank you. So let me share slides now and go ahead with the presentation. So I have no disclosures, and these are the learning objectives which have been previously posted. But first, what we're going to do is just show a couple of pre-test questions. So the first is a 34-year-old man with untreated HIV, CD4 count of 38, diagnosed with Mpox. Which of the following management strategies is most appropriate? A, administer the Jynneos vaccine in a series of 2 doses 28 days apart. B, initiate tecovirimat 600 milligrams orally twice daily with a high-fat meal and treat for 14 days. C, delay antiretroviral therapy initiation until the mpox lesions have resolved. Or D, initiate ART while treating mpox and monitor closely for severe disease. So we have most people doing D, initiate ART, but a smattering of giving the vaccine now, giving tecovirimat, about 12% of people, and then 3% delaying antiretroviral therapy. So we'll come back to that at the end of the session. And question number 2. A 57-year-old woman with HIV, CD4 count of 110, presents to care with 3 weeks of watery diarrhea, fatigue, and a 10-pound weight loss. She reports eating several prepackaged salads but has not traveled internationally. Routine bacterial stool cultures are within reference ranges. Which of the following is most appropriate for the next step? A, initiate empiric ciprofloxacin 500 milligrams orally twice daily for 7 days. B, order specific stool modified acid fast stain for cyclospora. C, order specific stool PCR test for norovirus. D, reassure the patient that the illness is likely self-limited and will resolve without treatment. We have 84% of people choosing specific diagnostic test for cyclospora, 7% initiating Cipro, 8% PCR for norovirus, and just 1% for reassuring the patient without further diagnostics. We'll come back to that at the end of the presentation. So why are these outbreaks becoming more common? Well, they're due to several factors: global travel and migration. What was just took many months to get to one part of the world from another is now just a plane ride away. We've had a lot of migration, both from war and other social effects that bring people from one to the other, one area to the other. Urbanization, of course, as we have we need more housing. We're going into different places, and our cities are becoming more crowded. Climate change, we can have a whole talk about that. We'll talk a little bit about that during this talk as well. The animal to human interfaces, as we interact with animals more and more, they are exposing us to new infections. Antimicrobial resistance, of course, and then declining vaccination and public trust. And if you look at this graph, I really love this graph. The size of the fuzzy balls indicate the proportion of the actual number of people infected. So, for example, you can see that Spanish flu in 1918 affected 40 to 50 million people. HIV, AIDS, 25 to 35 million. And then COVID, more than 7 million people. But what you can see is that the number of fuzzy balls is increasing as we go towards modern times. And it's due to all of these factors. So first, I'll just show you a few minutes of this video from the BBC.
Flu has another trick up its sleeve that not so many other viruses have. If two flu viruses infect the same cell, they can shuffle chromosomes between one another, and a virus can be born which has genes from both parents. And that's how previous pandemics have arisen. And it's a real concern when we think about a dairy worker who's gone to work with flu and then gets H5N1 as well.
So if a human had human influenza and then were unlucky enough to get avian influenza from a wild animal or from a farm animal, the human could then be the mixing vessel.
Exactly. The virus will have a really good opportunity to start shuffling genes and get a virus that can maybe infect humans more efficiently.
Do we know much about what the virus has to do to move from being a problem for birds to being a massive problem for everyone on Earth.
So we would need the virus to be able to replicate much better in the human nose. The worrying thing is we're finding the cattle viruses grow a lot better in these human nasal cultures than, for example, avian viruses, which suggests that this virus, as it's evolved in cattle, is one step closer to being able to infect humans efficiently.
How worried about this are you, Tom?
I think some of the worst case scenarios that are out there for what a H5N1 pandemic looked like are the sort of thing that keeps virologists up at night.
So we'll get back to that, and that of course is referring to avian flu. And although it's faded into the background from much of our news stories right now, things are still happening in the animal world, and I'll get to that. But the way I think about emerging infections, it can easily become a list of things, but I've grouped them into these boxes, which is the way we can think about our patients, presenting with respiratory illnesses, presenting with a rash, presenting with diarrhea, being bitten by mosquitoes and ticks or other insects. And I'll also talk about what's coming up. So again, 4 boxes of how to approach, fever in a returning traveler or an emerging infection, respiratory illnesses, rash, diarrhea, and insect bites. And of course, there's neurologic illness, which I wouldn't get into as well if you want a 5th box. So let's talk about respiratory illnesses. And again, the short video really was speaking about H5N1, avian influenza, and avian influenza in general. H5N1 in particular has been around for about 30 years, with now crossover into more than 50 mammals, including sheep and other animals I'll get to. Humans are incidentally infected with about a 50% fatality rate. And there have been about 1,000 cases globally. Starting in 2024, of course, we in the US and other parts of the world have seen dairy cattle infected most prominently, with about almost 1,000 dairy herds now in 17 states. And of course, poultry with more than 170 million chickens infected and or killed. Of course, that led to the increase in the price of eggs. In terms of human disease, 71 confirmed human cases in the US since 2024, with 1 death, none in the last few months, luckily. But avian flu continues to, be in the background. Right now, actually around the July 4th holiday, it arrived in Australia for the first time. It was the only continent that didn't have H5N1 until now. That's affecting birds, not yet poultry or humans, luckily. In California, we've had elephant seals infected for the first time. And of course, you might remember that in South America, in Chile in particular, there were a lot of seals, again, thousands of them that died from H5N1. In the United States, people are developing vaccines for different animal populations, like Hawaiian monk seals, in a way to keep them alive or to preserve them because they're endangered. Poultry flocks continue to be infected, even though the price of eggs has gone down. You look every month there is a poultry farm in one part of the country being affected, Wisconsin, Rhode Island, etc. There's no proven human-to-human transmission yet. The risk is still low to the general population, but like the video alludes to, it only takes, as more and more H5N1 is crossing over to mammals and it continues to reproduce, at some point it will get a mutation that can then reassort with our human influenza and then give it superpowers to infect humans. This CDC MMWR report was just recently published. This was the one that had a delay in publication. It showed that a cat can actually affect a human, infect a human, H5N1 from a cat infecting a human, rather than the typical scenario of humans going to cats. So again, they are, crossing over to more species. But H5N1 isn't the only avian flu. There's H9N2 that's been increasing in prevalence. There's H5N2, which was described in Mexico, the first human case, and led to death, and then H5N5 in Washington State, also leading to death. And what it really speaks to is that, you know, even if it's not H5N1, it's likely going to be an avian influenza that will cause our next pandemic. The last five flu pandemics have all had its origins in avian flu. So how to keep yourself safe from avian influenza? Get your human flu shot. You want to reduce the chances of the avian flu, exchanging genes with the human flu and getting superpowers to be able to cause more invasive disease. Don't handle sick cows or animals, of course. That goes for West Nile virus as well. Don't drink raw milk or cheese. Don't feed pets raw milk or meat, particularly cats, because they get particularly affected with H5N1. And wear PPE if handling sick birds in backyard flocks. So the one death that we had in the United States was somebody with older individual with comorbidities who had backyard chickens, and likely the birds flying overhead infected the flock, and then the individual got H5N1 in that way. So my pearl for this section is think of H5N1 in a patient with influenza-like illness or conjunctivitis who has recent exposure to dairy cattle, poultry, or wild birds. The diagnosis of H5N1 begins with exposure history and not the chest X-ray, because many of these have not presented with full-blown pneumonia at this moment. The other box to think about these emerging infections is things that cause rashes. And of course, the poster child right now for that is measles. Measles has been eliminated in the US since 2000, but we're at risk, of course, of losing the elimination status. That meeting will happen when they'll decide that. I think everybody expects that we'll officially lose our elimination status. This will be later in the fall. There have been, so far this year, more than 1,000 cases in the US in multiple states and 3 deaths in the past year. This is in contrast to just 2023 during the pandemic when we had 59 cases. Now we have more than 1,000 so far, which is more than even all of last year. But if you think the US is bad, there's Canada, there's Mexico, and then there's the rest of the world, including Europe, where there are now more than from the last official reported numbers in 2024, there are more than 127,000 cases in Europe, the most in 25 years, compared to like 1,000 in 2022. Most of the cases have been unvaccinated children and teens, and most of the cases in the US until the outbreak in West Texas and Oklahoma and New Mexico have been people coming from abroad and coming back to the US and exposing the vulnerabilities of unvaccinated populations or individuals. Remember that the symptoms of measles are the 4 C's in a rash: cough, conjunctivitis or red eyes, coryza or head cold or nasal discharge, and Koplik spots, these white little spots in the cheek. And then you get this full body rash. Vaccine is one of the most effective vaccines we have. 93% at 1 shot and up to 97% with 2 shots. It's the most infectious agent that we know of. You can be in a room after somebody with measles has left the room 2 hours ago, and you can get measles if you are unvaccinated or undervaccinated. There's no treatment for measles. So when do you get a measles booster? I think most people who got any shot they're generally protected, but there might be some vulnerability when there was a different shot to a smaller proportion of people between 57 and 68. Those before 57 have most likely gotten measles, from the community. Anyone who's had 1 dose of MMR might think about getting another, but checking the titer first. And additional considerations include college, healthcare, living with immune-compromised individuals, traveling internationally. And the babies, 6 to 12 months, are a special case. We've had, of course, we start measles vaccine at age 12 months, and then at age 5 before kindergarten. But there have been several cases of babies traveling abroad because there's so much measles now, coming back and getting diagnosed with measles. So the CDC has guidance for those between 6 and 12 months old, where you can get an early shot, but you need to resume the regular shots at age 1 and age 5. You can also check a measles IgG to check immunity. My hospital, UCSF, mandated healthcare workers to all prove that they have measles immunity. So I think for those who didn't have the vaccination records, getting a measles IgG was the way to show that. So my rule for measles is try to suspect measles even before the rash is fully developed. Think about airborne isolation in a returning traveler or potentially exposed patient with fever, cough, coryza, or head cold, or runny nose and conjunctivitis. What about Mpox? As you know, there was a global outbreak starting in 2022 with almost 100,000 cases in 118 countries. The US had about 30,000 cases in three main cities, primarily Los Angeles, San Francisco, and New York, but many other cities around the countries and communities. 58 deaths. Most of these deaths were in people with advanced HIV and uncontrolled viremia. Cases are down but not eliminated for clade 2, which was that outbreak in 2022. We've been going up in number of cases per week from less than 10 last year to definitely in the close to 20 a week now in the United States. That's different from what's happening in sub-Saharan Africa now, which is kind of the OG Mpox, which is clade 1. That currently is affecting more than 50,000 people. For Mpox in general, for clade 2, which is still circulating in the United States and going up and down, and particularly we just had Pride Month in June. That is really the risk groups for that, as you know, is men and trans people have sex with men, where in the United States we have 98 to 99% of cases amplified by gay saunas, other gatherings in the original outbreak. And the news that you probably all know by now is that there have been 2 randomized controlled trials, one in the United States in the adults and one in the Democratic Republic of Congo, in showing that there's unfortunately no benefit, although tolerated well, for tecovirimat or TPOXX. And so that was a little disappointing to a lot of people. So it's really just supportive care for now. The vaccine is very effective. It's essentially not a live vaccine. It's replication incompetent, so it's functionally not live. Safe for everyone, including for those under 18. The 2-dose vaccine can get you up to 66% efficacy, and 1 dose 36 to 75%. So a lot of the efforts have been in encouraging individuals at risk to get not just the 1 vaccine at least, or the series of 2, but to complete the series. As you remember, when we had short supply, we had proof of concept that giving it subcutaneously can lead to, having more vaccine available to individuals as opposed to the regular intradermal administration. These are the indications which you know well: persons who are gay, bisexual, and other men who have sex with men, transgender, non-binary people who in the past 6 months are basically at risk with at least 1 STI, more than 1 sex partner, sex at a commercial sex venue, or in association with large public events, or people who are sex partners, or people who anticipate experiencing any of the situations described above. My proof for this section is that severe rectal pain or odynophagia may be the first presenting symptom of Mpox and should prompt a careful skin and mucosal exam. Most of the Mpox, as you know, is in the United States, has been around the genital area. The third box of approaching these emerging infections is diarrhea. And the sort of poster child for diarrhea, of course, is norovirus. This picture showed just a few weeks ago Ruby Princess that docked in San Francisco. And of course, the princesses were famous in the early COVID years, or the COVID year in 2020, for a place where a lot of people got COVID, and they were sort of docked abroad in the harbor, and people were worried about having them come out Well, they're also implicated in noroviruses, and this cruise ship that came by just a few weeks ago in San Francisco was notorious because they had just had this outbreak of more than 100 passengers. And then they had all the new passengers go in, and there were a lot of people nervous about whether or not that short break was enough time to really disinfect and reduce the risk for the passengers coming in. Of course, if the crew remained the same, that also potentially could increase risk. So norovirus is the leading cause of acute gastrointestinal outbreaks worldwide. It's extremely infectious. Transmission is via person to person or contaminated surfaces. For HIV patients, they can have persistent viral shedding, have chronic diarrhea, recurrent illness. Management is supportive. We have no vaccine or antivirals, and we prevent norovirus by hand washing with soap and water for the right number of time, 20 seconds, sing happy birthday or your favorite song. On cruise ships, we typically want to sing Row Your Boat. And hand sanitizers do not work. So that's the pearl for norovirus. So my pearl for norovirus, again, is to think of norovirus in a patient with HIV with watery diarrhea and vomiting. So with norovirus, as opposed to many other kinds of diarrhea, like traveler's diarrhea, vomiting is a big feature of it. So if you're vomiting and you have watery diarrhea, think of norovirus. The illness may be more prolonged with persistent viral shedding in those with advanced HIV and advanced disease. And of course, everybody's talking about cyclospora now. Who would ever think that cyclospora would become so famous? So it's increasingly recognized as a cause of foodborne outbreaks. It typically happens between May and August every year in the United States, at around 50 cases or so per state. So what's happening now in Michigan, parts of Ohio, Illinois, it's one of the largest outbreaks we've had ever, with more than 3,000 people in Michigan sickened. And that's probably just the tip of the iceberg because not everybody who has cyclospora is identified. Typically happens in spring and summer. The way you get it is basically the parasite is in the stool. The stool gets out and contaminates the soil or irrigation system. And the parasite it's not infectious at that point, so there's no human to human transmission. It needs to stay in the environment for a couple of weeks or so, and in high temperatures, it begins to sporulate, and that form becomes infectious. And that's why these vegetables become at risk, and particularly those with very big distribution centers, so the supply chain. And as we eat more and more packaged salads and from big distributors, we're seeing more and more of these outbreaks over time. So transmission is really through cilantro, basil, other herbs, leafy greens, berries, things that you can't take the skin out of. So generally things that are safe are things that you can peel, like bananas or melons because you don't eat the skin of the melon typically without cooking, or mangoes or oranges. Those are the things where if you wash your hands and you peel it, you're going to be at very low risk of contamination of the inside part of that fruit. People get symptoms by, first of all, the incubation period is 7 days. So it's a challenge because like food poisoning, you get it 6 to 8 hours after. You get it very quickly and it leaves very quickly. With cyclospora, you wait a week, you don't even remember what you ate. You get this profuse watery diarrhea, which has been dramatically described as explosive in the media. I mean, in medicine, we use that term explosive a lot, but I think a lot of people have been alarmed by the term called explosive. It's not like pop rocks or 4th of July fireworks. I have to explain to people that is mainly just a medical term. And together with cramping and nausea. HIV patients can present with chronic diarrhea that can last for weeks and weeks. I think if anything, it really is highlighting the fact that some of these chronic diarrhea cases that we see in our HIV patients may be treatable, for example, cyclospora. because you need specific testing for it. Of course, you can use some of the molecular tests that are increasingly used more in the hospitalized setting, but in the clinic, we may or may not use these specialized tests, and they may not detect cyclospora. You treat it with trimethoprim sulfamethoxazole for 7 to 10 days in most people. For those who have advanced disease, you can treat it for longer, depending on the situation, sometimes 2 weeks or 3 weeks. You prevent by washing vegetables carefully. I think, if at this moment, if you're living in Michigan, for example, you probably wouldn't eat bagged salads, and probably would take a whole lettuce and peel off the outer edges and eat the inside of the lettuce. It's the equivalent to peeling a fruit. Cooking to 168 degrees Fahrenheit or 80 degrees Celsius would pretty much kill the parasite. And the heartbreaking news is that right now there's a suspicion that Taco Bell, the distributor of the food for Taco Bell in Michigan and Ohio, Illinois, has been suspected most recently in the last hour or so. So I think we may be getting some answers. But in the meantime, you have these thousands of people infected. So my pearl is that persistent watery diarrhea in a patient who has eaten fresh produce should make you think about cyclospora even without international travel. In fact, most of the cases that we see now in the US have been domestically acquired. In the old days, it was somebody traveling abroad to a hot country, because again, that's where cyclospora can sporulate and then become infectious, and then coming back to the US. But now we're seeing, as we import more things and we have bigger distribution centers, it's very easy to infect a lot of people all at once, as we're seeing in Michigan right now. Remember that if you diagnose it, it's treatable with trimethoprim sulfamethoxazole. What about Ebola? I put this in the diarrhea section because that actually is one of the more common ways of presenting with Ebola, even though we think about hemorrhage and bleeding. Ebola was declared a public health emergency of international concern. And recently, this is the 9th public health emergency of international concern since 2005. So they're coming fast and furious. This is the 17th Ebola outbreak in Democratic Republic of Congo. And in 2014, of course, we in the US, it hit all of us in consciousness because there were 28,000 cases, mostly in West Africa, and a lot in urban centers, 11,000 deaths, 11 cases in US, some in healthcare workers, a couple of the first 2 cases. And why is this Ebola outbreak different? There's an unknown scope and scale. Of course, because many of these areas are rural, diagnostics were hampered. This is a different variant. There's armed conflict in the region. There's a lot of migration in the region, not only because of the armed conflict, but because of the economy, which is due to mining. And so you have a lot of migrants coming in as well. And then more specifically and alarmingly, we've, as you know, decreased funding to that area. In terms of USAID, in terms of and the WHO pulling out of WHO, left the WHO with much less resources, more than 40% less. There is less support of the CDC, which have normally been there and anticipated a lot of this. So I think these are all vulnerabilities. And of course, the fourth factor for less funding is that the US has pulled funding from Democratic Republic of Congo and Uganda, in addition and separate to all the other factors I mentioned. So we think that Ebola will continue to result in periodic outbreaks in sub-Saharan Africa. Transmission is through direct contact with blood or body fluids. It's not airborne like COVID, like measles. And it's called a disease of compassion because it is the healthcare workers who take care of these individuals. It is the family members who prepare these individuals for funerals. They are the most likely to come in contact with these bodily secretions and then get infected. Clinically, you have a dry phase and a wet phase. In the dry phase, you have fever, headache, and myalgias. And this is then leads to the wet phase, which results in really, really profuse diarrhea. Um, you may have some bloody diarrhea, but a lot of times it's watery diarrhea, vomiting, and that's how people get infected. Bleeding is really in a minority. With the old strain, with the predominant strain of Ebola, which is the Zaire strain, which was the 2014, outbreak, and many other outbreaks, that we have two monoclonal antibodies for, not for this current strain, although that's in development. And for vaccines, we have two vaccines for that other Zaire strain, but not for the current strain. But there are three vaccine candidates being developed right now. So, you know, although it's again faded from our news stories, it's still happening very actively in Democratic Republic of Congo and spilling over into neighboring countries, including Uganda. So my pearl with this Ebola is that most patients with Ebola do not present with hemorrhage. Profuse watery diarrhea and fever in a patient with recurrent travel and potential exposure history should prompt isolation. So again, thinking about where the patient is coming from in the context of one of those buckets that I talked about is really going to serve you well in the future when we think about these emerging infections, because again, they're emerging, so you're not usually thinking about them when you see these patients present with these sort of typical syndromes. What about mosquitoes and ticks and that box? I think dengue has been getting a lot of press, mainly because of it's encroaching into areas that haven't seen dengue before, as well as a lot more cases in places that typically do see dengue. So it's the most common mosquito-borne viral infection worldwide. In the US, I've seen it in Florida and Texas and Puerto Rico, Guam, and some of the territories, and now in California. So LA for the last couple of years or so, I've seen cases from mosquitoes in LA, not from people traveling and then get diagnosed in LA, which again speaks to the warming trend that we've been seeing over time. Clinically, people present with fever, headache, retroorbital pain, myalgias that are so intense that people call it breakbone fever, a rash, leukopenia, and thrombocytopenia. Severe dengue, of course, if you get bitten, you get infected with one of the four strains of dengue, you get bitten by a mosquito with another strain, you are at risk for getting severe dengue or hemorrhagic dengue. That's manifested as mucosal bleeding and fallen platelets that come before complete shock. Treatment is supportive. We don't have any antivirals for dengue. The other pearl is to avoid NSAIDs until dengue excluded, mainly because it affects the platelets so much. So Google, of course, recently in the news because they're planning to release all these sterile mosquitoes in an attempt to get a hold of, control the mosquito population. Although we don't have Aedes aegypti a lot in Hawaii and California, we have Aedes albopictus, which can also be infected by dengue. So my pearl in the dengue section is to think about dengue and malaria in a febrile returning traveler just with thrombocytopenia. That might be the first sign
Here
of
for
dengue.
someone, don't you? You shouldn't leave yet.
I think another tick-borne syndrome that I want to talk about, because again, it's flying under the radar, but people are paying more attention to it more and more, is something called alpha-gal syndrome. So basically what happens is that you get bitten by this lone star tick, which is very predominant in many parts of the US, including particularly in the Southeast. And the tick saliva has these proteins that sensitizes your immune system when you get bitten by the tick and get exposed to the saliva to this alpha gal, which is present on a lot of red meats. Some people think some medications and other foods, and then you get an allergic reaction. So you don't even know about this because you were bitten by this tick in the summer, and then all of a sudden later on in the year you start eating this meat, and then a few hours later you start getting hives or urticaria, and or in some rare cases anaphylaxis. So that is really what alpha-gal syndrome is. So it's a delayed 2 to 8 hour allergic reaction after eating red meat, in particular beef, but as well as pork and lamb. It ranges the symptoms from urticaria to anaphylaxis, although some people think even more, some cases of IBS, etc., might be due to alpha-gal syndrome. You diagnose it by doing a specific IgE testing to this serum alpha-gal, and it's positive. If you are diagnosed with it, avoiding meat, and if you were diagnosed with it and had an anaphylactic reaction, of course, carrying around an EpiPen. The range of this tick is spreading, just like the range of the tick that causes other diseases like Lyme disease. So we're expecting a bigger geographic range in the United States and elsewhere to be at risk. So my pearl in this section is that unlike most food allergies, alpha-gal syndrome typically presents several hours after eating red meat. This makes the diagnosis easy to miss unless you ask about tick exposure. I also want to talk about screwworm. So this is not a tick or mosquito, but the maggot of a fly. And that has also been getting a lot of press. So it's caused by the larva of the New World screwworm fly, which loves living tissue. Most of these maggots and stuff, they love dead tissue and they feed on dead tissue. This is very different because it thrives on living tissue. And after decades of successful eradication in the United States, there's been a reemergence of screwworm after the northward spread from Central America and Mexico. So what happened in the 30s, it used to be a big problem in cattle, and the US developed all of these factories that produced sterile male flies that will mate with the females, and then they would not produce any viable progeny, and definitely not any maggots that can affect living tissue, mainly of cattle. Humans are really incidental hosts. And how do people present? They present with these painful, non-healing wounds with drainage, visible larvae. You may or may not see it. It smells bad, and you can get secondary infected with bacteria. And the treatment is mechanical removal of larvae. Don't do it at home. And then what has been happening is that we had these successful eradication efforts by making these factories with all these sterile flies. And then we started making these factories in the border and then working with governments in Central America and Mexico to also have these sterile flies. And those efforts have petered off over the last few years. And what you see is that there have been more and more flies. The flies have been marching upwards, and now they're in Texas and other states in the South. And it's probably going to be a multi-billion-dollar industry at risk, which is cattle, and then humans get incidentally infected. And when they're incidentally infected, it could look pretty morbid. This video comes from JAMA, and I'll show you what happens when the screwworm, which is the maggot of the fly, affects an open wound in the lip of this individual. So then most of them have to be surgically removed. So my pearl in this section is that you think about screwworm in a patient with a non-healing wound and travel to an affected region. Early recognition and surgical removal can prevent extensive tissue destruction. There's also a report, I think it was in MMWR just a few months ago, from a traveler going to Atlanta who had screwworm as well. So even though we're also seeing it in animals in the United States and probably going to affect humans again soon, certainly travelers coming back from endemic countries could have this as well. So where do we go from here, and what's going to be next? So even before the pandemic, the WHO had coined this term called Disease X, and it's really a placeholder for the next pandemic. And that was really prescient because COVID came. But again, what I'm encouraging all of us to do is to really think and to be in, readiness for seeing something that might be new. And this represents the knowledge that a serious international epidemic could be caused by a pathogen currently unknown to cause human disease, like H5N1. Will likely be a respiratory virus. It wouldn't be screwworm. It wouldn't be cyclospora because, again, that's not human to human. You probably want something that's airborne. And so what do we need? We need to strengthen primary care. We need research and development. We need to spend more and spend smarter. We need to focus on prevention. Only 3% of our budget, even less than that at this point, is spent on prevention. And we need to share data. All of these at risk right now. So our key threats are, of course, vaccine confusion. We could spend an hour or more talking about that. Pulling out of the WHO, like I mentioned, hampering the current Ebola outbreak. I didn't talk about hantavirus, but of course, the CDC had a much delayed entry onto the boat before that got spread and communicated to the rest of the world. The CDC siege, the loss of positions, the cutting out of the pandemic preparedness office in the White House, shifting priorities of NIH funding, the canceling of $600 million to develop bird flu vaccine using mRNA. I must say that one of the candidates for the current Ebola strain vaccine is an mRNA vaccine from Moderna. So they're still doing this, even though we've pulled a lot of funding as the US from those efforts. And then, of course, war, what's happening in Iran, other parts of the world. So what can you do? What can we all do? I think detect disease as early as you can, recognize unusual patterns. You are the first detection system. We are the first detection system. Avoid anchoring bias. Oh, it's just the flu without thinking, well, could this be something else? Like flu-like, but it's not flu. Maybe it's avian flu. Maybe it's something else. Be stocked with the right PPE, communicate clearly. I think that's going to be really, really important for all of us because misinformation spreads faster than pathogens. Adapt quickly, be flexible. So this is me camouflaging myself as the floor in Taylor Swift's wedding venue. So my take-home points are emerging infections are increasingly affecting routine HIV care. Advanced HIV is a major risk factor for severe disease. A careful exposure history, that is travel, sexual history, occupational history, animal exposure history, vector exposure is a high-yield diagnostic tool. Early recognition and public health engagement may improve community outcomes. And preparedness is more important than memorization. So what I tried to do in this talk is really give you something to put something in a box rather than memorize a bunch of lists or think about a lot of lists. Is it a respiratory syndrome? Is it a rash? Is it diarrhea? Have they talked about being bitten by a mosquito or an insect? So there have been as many plagues as wars in history, yet always plagues and wars take people equally by surprise. So coming back to the questions, a 34-year-old man with untreated HIV, CD4 count of 38, diagnosed with Mpox, which of the following management strategies is most appropriate? Administer the Jynneos vaccine in a series of 2 doses 28 days apart. Initiate tecovirimat. Delay ART until Mpox lesions resolve, or initiate ART while treating Mpox and monitor closely. So most people got it right, 88%, which is true. We want to initiate ART because uncontrolled viremia is probably the biggest risk factor for not just not being infected, but for getting serious disease and for mortality. It's not really a CNS infection, so we don't worry in the same way about initiating ART at the same time as the person has the illness. Because again, it's not in an enclosed space, so I wouldn't delay it. And again, we probably wouldn't use tecovirimat based on those clinical trials at this time. So unfortunately, even though there's some biologic plausibility, it's not borne out by the clinical trials. And then the vaccine, uh, there are some things if you're exposed, you can give the vaccine. And mpox, for example, if you don't have disease yet, but if you have the diagnosis, the vaccine is unlikely to work. But the reason why the vaccine might be an interesting post-exposure intervention is because the incubation period of mpox is so long. So the next question is, so this is what I talked about. Advanced HIV is the strongest predictor of severe mpox, and ART should be initiated promptly. Tecovirimat not been shown to be beneficial in randomized control trials. Post-test question 2, HIV CD4 count of 110, 3 weeks of watery diarrhea, fatigue, 10-pound weight loss, ate salad, no travel internationally, routine stool studies negative. What's the next step? Cipro for 7 days, stool test to look for cyclospora, specifically stool test to look for norovirus with PCR, or just reassurance. So 94%, which is everyone's worried about cyclospora now, which is right. Don't have to travel internationally to get this anymore. You're getting a lot of diarrhea without necessarily a lot of vomiting, and HIV individuals can have a lot more persistent virus and chronic diarrhea symptoms as well. So that's essentially what it is. You need to really uh, do a specific test to get cyclospora. A lot of the BioFire tests can find it, but the regular routine studies may not.
Peter, thank you so much. That was a fantastic overview and an enormous amount of information in a really impressively short period of time. There are a number of great questions coming in. Please feel free to continue to put your questions in the Q&A. Remember to include your name and your institution when you do so. We will get to as many of the pre-submitted and current questions as possible, but we have time for sure. We have about just shy of 25 minutes. So again, please put your questions in. Peter, the first one, I'm going to sort of take in parts and add a little bit of the confusion that I see regularly in our own practice too, which is about measles vaccination. So I think the when to give a booster is confusing. And so let's take the first scenario, which is in someone who you know got 2 shots, has a negative measles titer, and has comorbidities, has perhaps controlled HIV or or some other potentially immunocompromising condition.
Yeah, so I think somebody who has 2 shots and you can't, and then you do a IgG and it's undetectable, you can try, and their HIV, yeah, their CD4 count is above 200. You could, because again, under 200, you worry about giving that live attenuated vaccine. So I would give a vaccine, and because it's pretty safe in that population. And then you might want to check a titer sooner rather than later. I think one of the, I think as if that person lives in a community with less than 95% vaccination rate in particular, or traveling abroad, you'd be a little bit more worried. And that is increasingly becoming the norm rather than the exception now. Yeah, you give a shot, but then don't, check a titer soon after. So like within a month or so, and that might give you assurance. So that's probably where I would start. But, I think even if you don't detect a detectable IgG, there might be memory T cells in there.
Yeah, and I think that's the piece that's been confusing people so much. It's easy if you don't know if the person had their vaccinations, but when you do, elderly people is another topic that's come up regularly is when do you boost them, knowing that they had, or older people, that they had 2 of the appropriate shots. And in addition to that, one of the questions in the Q&A also was, is there any situation where you would ever consider giving a measles booster to someone with a CD4 count under 200?
I mean, I think that is an interesting question. I mean, in the setting of, I can imagine the scenario, you're in the setting of an active outbreak, and maybe they're under 200, but their trajectory is really high and they've been undetectable for forever. Functionally, that person is not going to be at risk as a typical person under 200 with, a sky high viral load and they're dropping their TD4 count. So I think, you talk to the patient, you talk about the potential risks and benefits, but that person on the in between might be something you might think about. Wendy, how would you approach that question? I think it's a really interesting
No,
question.
I think it is an interesting question. And I totally agree with you that I think that the difference between somebody with uncontrolled viremia, that's a completely different host than someone who is undetectable, who has improving immunity, and particularly those folks who have been stable for years, who get a little bit stuck at a CD4 count just under 200, but have been controlled for years. I wouldn't do it normally, but in the middle of an active outbreak like we have right now, especially if you, for example, lived in South Carolina or Utah or one of these
Yeah.
places, I'd give it some serious thought.
Yeah. Thank you.
Next question. Can you speak about Mpox vaccine boosters? This is a hot topic. Is there rationale for when should we boost for Mpox? How long do we think immunity lasts after 2 Jynneos injections?
I think that's a great question. First of all, I would think about, so if you get Mpox in the community, like those cases in 2022 and ongoing, it's expected that that immunity is actually lifelong. I think with the vaccine, it's not clear, and I think there's been a lot of hope and call for doing vaccine trials now in people who have gotten shots to see what happens over time. But to my knowledge, that's not occurring. I would say that what the current thinking is, first of all, nobody knows how long immunity would last with a vaccine. The guidance currently is not to get beyond 2 shots and to try to get people as many people as possible their first shot who are at risk and definitely complete their 2 series shots. Um, the the thinking is don't give them extra shots and reassure people that even though they're breakthrough infections, that the Mpox that people have gotten after vaccination tends to be much milder and less impact on quality of life. So, who knows what the right answer is, but right now that is the guidance, and we need more data.
Right. And one of our attendees was asking, how do you differentiate, still on Mpox, how do you differentiate between anorectal Mpox and anorectal herpes, for example? As we know, the tests are sometimes challenging to obtain.
Yeah, so I mean, I think uh, you know, talking about risk, although the risk is shared a lot of times, looking at I think the HSV tests are very widely available, so I think ruling that out for sure. And then the other ulcerative diseases, of course, if it's painful, you're thinking Mpox, HSV, VZV, but VZV wouldn't be necessarily just in the genital without a dermatomal distribution per se, and then chickenpox VZV would be all over the body usually. And then, while you rule out HSV, and you might give empiric therapy for HSV, because that's statistically more likely, unless the person knew somebody who had Mpox too, um, because they usually come in groups. Yeah, focus on the HSV and work with the local health department to get a test because it's going to be really important to diagnose that patient so that you could do contact tracing and try to make sure the people around that person, if they have no symptoms, have been vaccinated.
I think you're right. I think we've let Mpox slide a little bit too far out of our conscious at this point, feeling like this could be over, even though you made the point today that there are still plenty of cases diagnosed. And so I think keeping that awareness high, some of the lesions are really nodular, and so that looks really different than herpes, but some of them are really ulcerated, and it can be really difficult to differentiate. I totally agree. Um, how about moving to our favorite topic of the day, cyclospora? Many of our patients with HIV in particular, but others as well, have bacterium allergies. What is second line therapy, or is there one?
Yeah, second line therapy is ciprofloxacin for 7 days. It's not quite as effective as trimethoprim sulfa, but it is somewhat effective. So you can try that if you diagnose it.
Perfect. Question about Mpox vaccine. Do we know if the Jynneos vaccine protects against smallpox? Which hopefully we don't need to worry about, but
Yeah,
know.
I think that's a great question. My understanding of that is that there is, cross reactivity to smallpox. I don't know, how it. I'll have to look up to see how it compares to smallpox against protecting against smallpox, and maybe people in the audience know that. But that is my current understanding. I don't know, Wendy, if you had any thoughts about that.
Um, what you said is exactly my understanding as well. The live virus vaccine, which we didn't use much in this outbreak, does have activity against smallpox. I would imagine this might, but I don't know that we know for sure. Fortunately, actually. Um, all right. I'm going to flip back to the measles vaccine because I think I left part of our questioner's question unasked, which is, what's too immunocompromised for the MMR vaccine? Specifically, what about patients on biologics, for example? We see so many different immunomodulating therapies, transplant patients, which I know you see often. We've got a guideline for HIV with the CD4 count of 200 with the caveats that we just talked about, but what about other immunosuppressing conditions?
So I think in most biologic therapies, I particularly the very serious ones like B-cell depleting agents, JAK inhibitors, etc., they're not indicated. I think the way I think about immune compromised patients and live vaccines is not it's not the people who can get it, but rather it's not the people who can't get it, it's the people who could get it. So it's the exception rather than rule. So that we know about HIV greater than 200, but pretty much everybody else, I think people are nervous about using live vaccines in. You might think about like somebody on low dose prednisone, like under 20, low dose methotrexate, those kinds of patients, but I think people are generally pretty nervous about using these live vaccines, except in the HIV over in immune compromise, unless your CD4 count is over 200 on your like some low dose of prednisone.
Yeah,
I don't know, Wendy, what if you had any thoughts about that?
no, I think it's difficult because we're lucky in the HIV world to have so much data and so much investigation into questions like this, and it's easy to come up with a number, which may or may not be exactly the right number, but there's a criteria. But when you're talking about multiple different immunomodulating agents, they all have different activity on different cell subpopulations and so on, and it's really, really hard to tease that apart.
I mean, I guess one point we could reemphasize is that if you know somebody's going to be immune suppressed, just like we do with TB and biologics, infliximab, you try to vaccinate them with all these things before they become immune suppressed. And certainly that happens if somebody's going to get chemotherapy or if they're getting, they're on the transplant list. I think we try to do as many vaccinations before because many of them we can't give after with good data, even though they might be way off from transplant. The other thing that if somebody has measles and they're immune compromised, you can give them immune globulin, kind of within a few days of exposure as another way to think about attenuating, a potentially bad outcome.
I'm going to turn to a couple of the questions that came in advance of your presentation. And a couple of these focus on hantavirus and Ebola and co-infection with HIV. And do we know if there have been cases of co-infection, and how would you think about HIV, Ebola, or HIV Hanta co-infection?
I'll start with Hanta first. So Hanta, there are relatively few cases that have been documented in HIV, so there's even less information about HIV and Hanta. But I think that somebody with uncontrolled viremia with many of these emerging infections would probably do worse. And I think that's been a common theme, even though there's less data. And with Ebola, many of the places where Ebola is happening is where there's also a lot of HIV. But surprisingly, there has not been a lot of data about Ebola outcomes in people co-infected with Ebola and HIV, as far as I know. However, one of the, what Ebola does, and what any emerging infection does, is it completely throws the infrastructure into disarray. So there are a lot of secondary effects of all of these outbreaks on care of people, just like COVID did, of people with HIV in many of these countries where Ebola and HIV coexist. But again, like with hantavirus, I would assume, and documented with Mpox and some of these other emerging infections, I would assume that people will do much more poorly if they have uncontrolled viremia.
It is striking how little data we have, I think, to your point of, destroying the infrastructure for monitoring other things, when we've had two huge outbreaks now in areas where there had to be a lot of HIV Ebola co-infection. And it is devastating to see how outbreaks can destroy really general health and public health overall. Okay, and do you want to make a comment? One of our submitted questions was asking about the differences in risk of transmission between Nombre virus, hantavirus, and the Andes virgin hantavirus. So that seen in North America versus that seen in South America.
Yeah, so hantavirus comes to the word from the river Hantan, which is in Korea, and it was first diagnosed in the 50s from uh, peacekeepers who were in the UN peacekeepers who developed sort of kidney failure uh, uh, and hemorrhagic, cystitis and kidney failure. That is different from what is in the United States and the Americas, and that's like the first big branch in the United States, but same way you get it, which is through excreta from rats, and you like sweep it up and you inhale it. In the US in the 1990s, so not that long ago, the first case of what was called sin nombre, because it didn't have a name, and I guess they decided not to give our American version a name. It was manifested as like complete lung failure, ARDS, and that is a very different flavor profile from Europe and Asia. So of the C nombre and the American variants, there's the Andes variant and the rest of them. So the Andes variant is famous for not only just causing ARDS and need for ECMO and lung respiratory failure, but it's the only one that's person to person. Every other hantavirus, including the ones that we get in the United States, and we get about 30 cases a year, and Gene Hackman's wife, as you recall, died of hantavirus in New Mexico. Those are not person to person, but again, this just happened to be the ship, wrong place at the wrong time, the right place for the Andes variant, got on somebody, incubated for a while, got on the ship, and then spread from person to person.
Thank you. I'm going to flip to mosquito-borne and talk a little bit, ask you some questions about Zika, chick, and dengue. The first question is emergence or the development of the virus in new territories or in sort of original, the locations where it was first found, is there an interaction with the virus in climate change or temperature, or is it the mosquito and climate change?
I think the answer is yes and yes, but the easiest factor that we can think about is, and the one where there's more data is just as it's getting warmer. So mosquito range is expanding. But I would also say on the other side, although that's less than the range expanding, is there are places that are getting so inhospitable to mosquitoes too because of extreme weather. But in general, they're expanding, and therefore you're getting more breeding of mosquitoes and they live for more of the year, and they can transmit these, mosquito-borne infections. The other thing is, but there is evidence that heat also increases, the replication of these viruses, and you have just a higher concentration. Whether or not that translates into more people getting infected, I think I haven't really seen great evidence around that. So that's kind of the range. The other thing, related to Zika, dengue, and chikungunya is West Nile and what's happening. And this year is also thought to be going to be a bad year for West Nile because of not just more, warm weather, but the extremes of heat followed by drought like we have in California. Because what happens is you have the heat and you have lots of happy mosquitoes and birds, and the mosquitoes bite the crows and the birds. And then you have drought, and then you have water supply that's concentrated, and all the mosquitoes and the crows come and hang out with each other more, and then they just exchange the virus. So you not only have more warm weather for longer, but you have drought, which can concentrate resources where you can have some of these animals commingling with each other, and therefore have amplification of the particular pathogen.
Peter, that is so fascinating. I never thought about scarce water being a place then where there's concentration. That's fascinating. Here in Colorado, it's clear we're going to have a bad West Nile year again. So there are vaccines internationally available for dengue and chick. Would you, I guess, first off, would you consider advising patients with HIV if they visit those countries to get those vaccines? And what are your thoughts about whether these will become available in the U.S. and the discontinued dengue vaccine, Dengvaxia, as well?
I think my sort of cynical comment about that is really that we don't think about these vaccines until it affects us. And I think it's affecting us, more and more. There are, two chikungunya vaccines in the US, as far as I know. I have to, at least two, I think. And they are, one of them at least is okay for immune compromised individuals. So I think having HIV patients or any of our patients or us who may be going on to a place where there's active chikungunya outbreak. Right now it's been kind of quiet, although it does pop up in the Caribbean and in the islands from time to time and causing these debilitating joint infections, to talk about that. So I think that is, so I think one of the chikungunya is contraindicated for immune compromised, but one is okay and they're licensed. The dengue vaccine is more limited, and right now they're not recommended for U.S. travelers at this moment. But again, like the person said, that they are available in other countries. So it's harder for me to talk about to really recommend that per se at this moment. With the chikungunya, I feel a little bit more bold in saying, because we have it available.
Well, Peter, I lost track of time in my fascination with your responses. So I think that was the last question that we can answer, and I didn't warn you in advance of that. But thank you so much. This has been really, really fascinating. And I would ask that we pull up the slides to close us out. So importantly, and germane to one of the questions in the chat right now, is that the information to evaluate the session and to claim CME should be in your inbox by 5 p.m. Pacific time tomorrow. And so please take advantage of that. And we also learn a lot from evaluations and what you would like to see more of in the future. There are a number of fantastic IAS-USA activities that are coming up. I want to point those out. Mike Sag is continuing to do his Going Antiviral series. The next one will be, or the most recent episode is the Progress in HIV Cure Research, where he had a conversation with Steve Deeks. On July 21st, so in 1 week, there will be a session on vaccination recommendations for children and adolescents, with the presenter being Bonnie Maldonado from Stanford. In September, the dialogue series on emerging infections and health threats, and you can see some familiar faces there with Dr. Chin Hong and Dr. Maldonado again, and Carlos Del Rio moderating the session. The in-person and virtual update, IAS-USA update on HIV, held in person in Chicago, is October 15th, and one can register for that. And finally, the virtual course Beyond ART, Hot Topics in HIV Primary Care, is November 16th. So we can fill your calendar up until the rest of the calendar year. And there's more yet to come beyond those things as well. Thank you so much. This has been a lot of fun for me, and I hope for you, Dr. Chin Hong, and appreciate the great engagement of our audience.
Thanks so much, Wendy, and everyone. This was a lot of fun for me.